Good morning. Today I'm going to talk to you about viruses from mom. My name is Mimi Ghosh. I'm an associate professor at the Department of Epidemiology at the George Washington University. Today's outline and learning objectives include learning about the immunology of pregnancy, the mechanisms of mother-to-child transmission, and then we will go over some specific viruses. First, let me introduce you to the concept of TORCH. TORCH infections are the term given to a group of infectious pathogens that can be passed from mother to child, and it stands for toxoplasmosis, others, and the others include a bunch of pathogens such as syphilis, hepatitis B, parvovirus B19, varicella zoster virus, Zika, and HIV, and then rubella, cytomegalovirus, herpes simplex virus. The names that are in bold on this slide are viruses, and those are the ones we are going to cover today. Maternal risk factors for acquiring these infections include lapsed immunizations in cases where the vaccines are available, and also sexually transmitted infections. The timing of maternal infection is a key epidemiologic factor because fetal damage usually depends on gestational age. And with the exception of herpes simplex virus, infections during the first trimester usually have the worst outcome. I want to talk to you about the unique responsibilities of the female reproductive tract, which has to balance this act of protecting against pathogens and at the same time supporting fetal health. The immune system in pregnancy is very unique. So the question to you is pregnancy a condition of immune suppression? And most people think this is correct. However, I would say the answer to this is no. Pregnancy is actually an unique immune condition that is modulated in a different way, but it is not certainly suppressed. Pregnancy is an immunologically active state. It is certainly not a blanket anti-inflammatory state. Let me give you some details in the next few slides. There are three states of pregnancy, immunologically speaking. The first trimester is a pro-inflammatory state. This trimester immunologically resembles an open wound because this is where the blastocyst breaks open through the epithelial lining and implants into the uterus. In the process of this, it damages endometrial tissue and kind of invades, and there's tissue remodeling in the uterus that occurs to accept the blastocyst. So essentially, it becomes a battleground of invading cells, dying cells, repairing cells. So this is a very inflammatory state. This is also when mom experiences the most of morning sickness. The second trimester is a period of rapid fetal growth and development. Mother, placenta, and fetus are symbiotic, and this is an anti-inflammatory state where the morning sickness goes away. The third trimester now up to delivery is where an inflammatory state happens again. In this, inflammation is necessary to promote the contraction of the uterus, expulsion of the baby, and rejection of the placenta. Therefore, pregnancy is both a pro-inflammatory and an anti-inflammatory state, and it depends on the gestational stage. Mother-to-child transmission, there are multiple mechanisms for this. In utero, this is transplacental, so mother-to-child through the placenta, and this results in congenital infections in the baby. During birth, this happens while the fetus is passing through the birth canal, and then postpartum through breast milk or kissing. Consequences of infections during pregnancy are multiple. And the mechanisms can include direct infection of fetus through the placenta, as well as indirect damage to the fetus due to inflammatory state in mom. In mom, this can result in preterm labor and birth, preterm premature rupture of membrane, cervical insufficiency, and intrauterine growth restriction. In the fetus, it can result in fetal death, long-term complications such as cerebral palsy, chronic lung disease, hearing loss, cataracts, microcephaly, as well as psychiatric disorders. Let's move on to our first virus that we are going to discuss today. This is herpes simplex virus, or HSV. Herpes simplex virus belongs to the family Herpes viridae. It is a double-stranded DNA virus. It results in lifelong infection of host and establishes latency in the host as well. Almost every person in the world are infected with a type of herpes virus, usually without knowing. So there's no symptomatic infection in many cases. In case of mother to child, the transmission is primarily during birth, and this is particularly bad if mom is asymptomatic, so she may not know that she's infected and will pass the virus on to her baby. Seroprevalence of HSV 1 or 2, and there's 2 HSVs, so 1 or 2, among pregnant women is high worldwide. During pregnancy, HSV infection has been associated with spontaneous abortions, intrauterine growth restriction, preterm labor, and congenital neonatal herpes infections. If you have seroconverted before, as I just mentioned, most people in the world actually have seroconverted to herpes simplex virus, meaning they have been exposed to the virus early in their life. If this is the case, then there is little risk to the baby. However, primary infection, if that happens during pregnancy, then there is a high risk of neonatal infection. 30 to 50% risk of neonatal infection happens if mom is infected in late pregnancy, and majority of the transmission occurs during labor and delivery. Neonatal infection can result in localized skin, eye, mouth infection. It can impact the brain, causing encephalitis. It can be disseminated, so it can spread throughout the body of the newborn, and that can result in up to 80% mortality if untreated. Infected newborns exhibit significant neurological deficits. The treatment guidelines include cesarean section for all women in labor if they test positive for HSV, suppressive antiviral therapy for mom, immediate antiviral therapy for the baby. Even with all these treatment options, infants with systemic herpes or encephalitis often do poorly. So the next virus on our list is varicella zoster virus, or VZV. This is also a type of herpes virus, and this is the virus that causes chickenpox and shingles. This is a double-stranded DNA virus. It also causes lifelong infection and latency. The incidence of varicella in pregnancy is about 1 in 2,000 in the US, and most women are immune lifelong, so before pregnancy, and that results in no complications. That is absolutely fine. But if you have primary varicella infection during pregnancy, that's when you see significant maternal and fetal morbidity and mortality. So approximately 10 to 20% of pregnant women who are infected with varicella will develop a severe pneumonia with a high mortality rate. And then congenital varicella syndrome happens in the infants, and that is characterized by microcephaly, hydrocephaly, cataracts, and mental retardation, also with a high rate of neonatal mortality, up to 30%. There are no vaccines for this. The antiviral drugs are used to treat, and this is one of the major drugs is called acyclovir. And there are many derivatives of acyclovir as well. The next virus on our list is CMV, or cytomegalovirus. This is also a herpes virus, a double-stranded DNA virus that results in lifelong infection and can have latency phase. Congenital cytomegalovirus infection is very common and affects approximately 0.2 to 1% newborns worldwide. If you look at the map on this slide, you'll see the shaded areas, the darkest shaded areas in black is high seroprevalence. As you can see, some parts of the world have that. And then the little dots you see are where you have high rates of congenital CMV live births, with the dark red dots being the highest. So CMV infects 60% women of reproductive age in developed countries and 90% in developing countries. This can happen early in life, and resulting maternal antibodies protects against congenital CMV in infants. The infections are mild or asymptomatic, and you probably will not know that you have been infected. Primary infection in mother during pregnancy, however, is serious, and this can result in transplacental transmission and also transmission by contact with genital fluids during delivery. Pregnant women can be infected horizontally from other children as well through urine, saliva, blood, and tear. Child-to-child transmission does happen in daycare setting, and asymptomatic shedding can occur. This is risky because if one child is in daycare and catches the virus and sheds it to a pregnant mother at home, that can also be risky for the fetus, the unborn fetus. The pathology and symptoms actually is a spectrum. Children can be born symptomatic with severe pathology that includes cerebral palsy, failing to thrive, hearing loss, vision loss, neurological disorders, or children can be born asymptomatic with very mild conditions. 80 of every 100 infants with congenital CMV infection never develop symptoms or disabilities. However, there are no vaccines, and again, the antiviral acyclovir type treatment of mom and newborn is the only treatment that reduces chances of transmission and symptom development. The next virus we're going to talk about is rubella. This belongs to a family togavirus, and this is a positive single-stranded RNA virus. Rubella infection during pregnancy can lead to miscarriage and stillbirth. When pregnant woman is infected with rubella in early pregnancy, she has up to 90% chance of giving birth to a baby with congenital rubella syndrome or CRS. 33% of infants born with CRS die before their first birthday. In 2019, an estimated 32,000 children were born with CRS. This is a condition that is fully vaccine preventable. The number of babies born with congenital rubella has decreased dramatically since the introduction of the rubella vaccine, and CRS has been eliminated in the US. Fetal infection is acquired hematogenously through the blood from mother to child, from mother to fetus. After infecting the placenta, the rubella virus spreads through the blood of the developing fetus, and as you can see in this picture here, it spreads into all organs and systems. This results in hearing impairments, cataracts, glaucoma, heart defects, developmental delays, neurological delays in the fetus. There is no cure, there is an excellent vaccine available, and prevention is critical. Our next virus is hepatitis B virus. This belongs to the family Hepadnavirinae, and it's a partially double-stranded DNA genome. HBV, hepatitis B virus, about 9 in 10 pregnant women with acute hepatitis virus infection will pass the virus to their babies. Between 1 and 2 out of 10 women with chronic infection will also do so. Now, interestingly, acute HBV infection during pregnancy is usually mild for the mother and not associated with a high mortality, and treatment is available, although it's mostly supportive. However, without any treatment, without any post-exposure immunoprophylaxis, approximately 40% of infants born to HBV-infected mothers will develop chronic HBV infection as adults, and approximately 1/4 of them will eventually die from chronic liver disease. The guidelines include universal screening and vaccination in pregnant women. There is an excellent safe vaccine. And there is provision for immunoprophylaxis for infants born to infected mothers immediately after birth. There's also provision for routine vaccination of all infants within hours of birth, within 24 hours of birth. Next virus we'll talk about is parvovirus B19, also known as the fifth disease. As you can see in the picture, parvovirus causes multiple symptoms in both mother and child. It is vertically transmitted from mother to child. This is a single-stranded DNA virus belonging to the family Parvoviridae. About 60% of adults are exposed and infected as children, and they may never know because they would have mild or asymptomatic presentation. Transmission occurs through respiratory route to mother and contaminated blood products as well. But if mother is infected while pregnant, virus can pass to fetus through the placenta. This results in miscarriage, intrauterine fetal death, fetal anemia, and hydrops fetalis. Clinical manifestations in adults can include joint pain and flu-like symptoms. In children, it causes what is known as the fifth disease, so it's kind of a red rash, particularly in the cheeks. But it can also result in more severe conditions such as anemia and myocarditis. The greatest risks are in those who already have hemolytic disorders and or have compromised immunity. There are no vaccines or drugs available for this. Our next virus is HIV, human immunodeficiency virus. HIV is a retrovirus and it can integrate in the genome of the host. So once it integrates in the genome, it does not come out. So infection is lifelong. Transmission from mother to child can occur in utero, so transplacental, during delivery, as well as through breast milk. Before the era of ARV, which stands for antiretrovirals, 50% infection rate, transmission rate happened at labor or delivery, 20 to 25% risk in utero, and 25 to 35% during breastfeeding. However, current rates are less than 2%. If you look at this graph on the slide, it shows you the rates of mother-to-child transmission before the era of antiretroviral and then after, the severe drop after antiretrovirals were available. So current guidelines include having antiretrovirals treatment to mother during pregnancy, preferably having C-section, so you are not having not natural delivery, no breastfeeding, and treating the baby immediately with ARV prophylaxis. Particularly zidovudine or AZT or nevirapine monotherapy single dose at 2 to 24 hours before delivery significantly reduces transmission. HIV has no vaccines or no cure to date. There are, however, some very real-world issues with the guidelines that I presented in the previous slide. In most of the world, testing of pregnant women may not actually happen until they're ready to deliver because women do not have access to regular physicians during pregnancy. C-section may not actually be feasible because many countries of the world, women will not have the resources or be able to afford a C-section. No breastfeeding is actually not a good alternative, again, in developing countries because maternal antibodies and breast milk support the infant through the first period of their lives, also providing nutrition. Maternal antibodies to many other diseases are protective for the infant during this time. And also formula availability may be very low. Women may not be able to afford formula or have access to clean water. So these are all the reasons where the guidelines that work very well in developed countries and practically reduce maternal to child transmission to zero are not necessarily feasible in other parts of the world. Currently, poor coverage of antivirals exists from pregnant women in many parts of the world. There is, however, some interesting developments in what we call cure in babies. In 2009, there was a baby known as Milan baby. This baby was aggressively treated at birth until about 3 years, when it was declared that this baby has no longer any virus in the system, no HIV in the system. So this was very exciting because everyone thought, oh, if you treat a baby born to an infected mother very early, then maybe there is no transmission of HIV from mother to child. However, after stopping antiretroviral therapy, virus was detected in the baby. There are some other cases like this. There was a Mississippi baby in 2010. In this case, the infant was aggressively treated within 30 hours of birth. However, virus was detected few years later in the baby. Then there was a California baby in 2013. In all these cases, mother was diagnosed only at delivery, and baby was treated, in case of the California baby, within 4 hours of birth with antiretrovirals. 11 months later, baby had undetectable viral load, but has to remain on therapy. So overall, the state of the field is cure is kind of elusive, so we are not exactly at the cure stage. However, remission seems possible if antiretrovirals are started very early. There has been a recent study with 54 newborns in 7 countries who started antiretrovirals 2 days after birth, and there has been good results with 4 of these infants remaining virus-free for 48 weeks and 1 remaining virus-free for 80 weeks. So this is a proof of concept that maybe perhaps one day we will be able to establish a cure protocol or a very controlled protocol for babies born to infected mothers. The next one on the list is Zika virus. Zika belongs to the family Flaviviridae. It's an arbovirus, which means it's arthropod-borne, and the virus is transmitted via bite of infected mosquitoes. It's positive single-stranded RNA genome, and it actually has some novel transmission routes. So definitely maternal to fetal, so vertical transmission, but it's also a sexually transmitted virus, and also ocular transmission can occur. Sexual transmission of Zika virus can potentially occur long after acute transmission, and virus has been detected in semen for more than 6 months after symptomatic disease. Mother-to-child transmission is transplacental, and infection during the first trimester of pregnancy is related to congenital Zika virus syndrome, which results in the microcephaly, the picture we all see, also shown on this slide, as well as severe cognitive, sensory, and motor issues in the baby. There is currently no vaccine or treatment for Zika virus. Finally, I wanted to show you one slide for SARS-CoV-2 and kind of talk about the state of the field, because we are still not that many years out of the pandemic and still thinking about SARS-CoV-2. This is not part of the torch pathogens that we talked about, but I thought this will be interesting. So COVID-19 has been associated with higher rates of maternal morbidity, preterm birth, and stillbirth. Symptomatic COVID-19 has been associated with an increased risk of C-section, preterm birth compared to asymptomatic COVID-19. And then compared with mild COVID-19 infection, severe infection is associated with preeclampsia, gestational diabetes, preterm birth, and low birth weight infants. So there seems to be no evidence of direct placental infection, so no vertical transmission or very rare vertical transmission, but we do see massive placental injury. So it seems like the damage that the virus does to the mother's system, mother's immune system, the high inflammation, the high rates of symptom, the physiological distress, that causes placental injury and causes some poor health outcomes for the fetus and the newborn. In summary, we today talked about the torch pathogens, we talked about immunology of pregnancy, mechanisms of mother-to-child transmissions, and we discussed specific viruses that are part of the torch pathogen, as well as SARS-CoV-2 in pregnancy. Thank you. This ends the presentation for today.